welcome to my other speaker, Paul. Good afternoon, everyone. Thank you. It's good to be back online. And while I am sharing my screen, I just do want to warn you, I can keep the kids quiet, but not the dog kitties. So if you hear a bark out of excitement, sorry about that. And I am armed. I couldn't get anything in time, so I am armed with my child's unicorn pen if there's any questions afterwards. But if you think of anything as we go and you don't have time to ask me now, please email me. I have no conflict of interest with regards to this topic, except saying it's one of my favorite topics. So anyone is always welcome to call me, to send me an email or a WhatsApp if you need some advice or just for a little bit of a chat. So getting right down to the topic of immunization, I could make it really, really fast for all of us. I know we've got load shedding and flooding and extreme weathers and RSV and all things to actually try and contend this afternoon with. So I can show you the 2015 EPI program that we're using in the state. It hasn't actually changed. There's been a lot of talk on what to include and how to include extra vaccinations. So watch this space. I think it is going to change in the next few years. Or I can even be fancy and show you the fantastic Pediatric Management Group 2021, which is the newest vaccine schedule. And in it, they show the diseases that we need to vaccinate and the vaccine names, and then when you need to give it, at what intervals, and it's nicely colored. And so we can all go home and have a gin and tonic. But it's not that straightforward. What I want to do this afternoon and really get into is the sort of behind the scenes stuff, you know, the nitty gritty of immunizations. And I always feel that if you understand something, it actually empowers you to relay messages and to explain things to not just your colleagues, but also to your patients. And I really want you to try and understand how the schedule came about and what type of vaccines we've got. Why do we have this sort of age indications and reasons? And it's sometimes just more straightforward than you think. It's not always just science that has caused these age restrictions and reasons for giving multiple doses. Those of you that heard my Catchup vaccination lecture, I'm just going to rehash a little bit on that. I think it's always important just to, again, have the main points if you have to work out a catch-up vaccination schedule for someone. And that I'm going to end with a rapid fire questions. And you could see I've got children that is going to school and that needs haberdashery stuff. And it's a fascinating, my mum used to call it a strointjieswinkel. I don't know if I can say that over a Zoom meeting, but you really walk into one of those into one of those shops and you get arts and crafts and you come back with more than 1,000 Rand worth of stuff to use. But so we're not going to spend 1,000 Rand this afternoon, but we are certainly going to look at other stuff that often we wonder about and don't always get all the answers. Okay, so starting right at the beginning where we always start, and why do we vaccinate? And it really is, the reason we vaccinate is because we want to become actively immune. And so if you look at that figure, it's an acquired immunity. Obviously, we need to acquire our immunity, or our immune system needs to be primed to actually be immune against a specific pathogen or the disease. And it's an active form of acquisition through artificial ways. Sure, we can all be naturally exposed to an infectious agent, but we obviously target our vaccination efforts to these infectious agents that have got an unacceptable morbidity and mortality profile. And that's how vaccines are developed. And if you look at surveillance data, if there's a specific disease that causes a lot of morbidity and mortality in a specific age group, that is obviously an optimal target for vaccination so that you can get an artificial but active immunity against it. Important for you to understand, if you go and look at vaccination throughout your life, which is another topic that I'm very interested in, is that both natural or artificial or vaccination immunity is not lifelong. Most of us have got waning immunity over time, and you either need natural exposure or, of course, artificial exposure through what we call booster dosages for some diseases throughout your lifetime. I think all of this is actually much clearer now that we've lived through a COVID pandemic and see the development of vaccines, who it was targeted for, the idea of booster dosages, and again, a third and a fourth booster dosages as we go along, and even probably over time, a new type of antigen that they need to actually put into our COVID vaccines. So I think for most of us, this principle is actually quite clear after living through the past 2 or 3 years. And so to make it easier, if you need to explain it to the patients, you would say that if you've got a harmful pathogen, you can package it in a way to get maximum protection, and you need to present it to the body's immune system. And so pathogen, we talk about vaccine preventable diseases, and we package them in a specific vaccine type, and we're going to look at that in a minute. And then you present it to the immune system, and that is through different routes and also through different schedules. And if you're interested in immunology and vaccinology, this is really where we are concentrating our efforts in the future, is the packaging of an antigen, is what is the route of immunization to get the required immunity. Are you looking at IgA immunity, IgG? What kind of immunity do you want? And what schedule would be ideal to reach the maximum immunity? And of course, also another important thing as we discuss with our patients is vaccines are made to prevent disease. In some, like hepatitis A, we can prevent it in 100% or 99.9% of cases, but most commonly, vaccines are to prevent the harmful effect of a disease. And so by that, we discuss the severity. So the severity, the morbidity or mortality coupled to a specific infectious disease, that is what we are targeting with our vaccines. So this idea that vaccine will prevent all disease is an incorrect sort of idea that I think is very quickly we need to sort of start, as we discuss with our patients, start changing that idea that we're not going to prevent all disease, but you are going to prevent severity of disease. And that's the important thing to target. So for all your registrars out there, again, this is really, really important to understand what is going to determine how well you initially respond to a vaccine. So what is determining the initial response when we start priming a patient with a vaccine? And there's 3 main things that is going to determine that. Is the type of vaccine that we are giving a patient, the type of antigen, and so they're the most important one for you that you would be familiar with is pneumococcal disease, where we can have either polysaccharide vaccine or a conjugate vaccine. So the antigen nature that we give to a patient is important. And then always the vaccine schedule. Usually the interval between priming shouldn't be less than 3 weeks. And so that's where we've picked 4 weeks as the sort of gold standard if we want to give a priming series. And then, of course, genetic determinants and so forth. So for those of you that study with pictures, this is just a picture to rehash that your primary vaccine response is going to be determined by the type of vaccine that you receive, the antigen in the vaccine that you receive, and the schedule that you vaccinate someone with. And then going further, the duration of that antibody response is again the type of vaccine that you're going to give a patient. And there, of course, if we can do a live vaccine, we know that it's very close or the closest to the real exposure, and that might possibly lead to longer immunity, but you're going to have more side effects. And in your severely immunocompromised patients, especially in patients with a T-cell defect, you obviously have got other issues where you can get, especially in vaccines that can still reproduce, can cause some side effects or serious side effects due to that. And then again, here the vaccine schedule is both looking at the primary schedule, but then also something else that you guys are familiar with now, especially with the COVID, is the idea of boosting. And as you can see there, that the intervals between boosting also becomes important. you need to actually have time for the priming and the affinity and the maturation of your T cells to actually have a proper secondary response. And so that would be important as you work out maybe a catch-up schedule, to not give a boosting dose too close to your primary dosages. So again, for those of you study with pictures, the duration of your vaccine response dependent on the type of vaccine and the vaccine schedule. And so then let's go to vaccine types. And I would actually advise all of you to go and look at Pollard's review. It was done last year, looking at vaccinology and any new developments. And it really is a fantastic, just a review. Obviously, our pediatric books are up to date. Whatever you want to use is also good. But this, for me, actually was just nice reading material and putting vaccinology into perspective on where we were and where we are today. So there are there's about 2 basic types, and then you can actually go into 3 and even 4 types of vaccines. But the easiest is to look at the top part, the pink and the blue, and these are live vaccines. So, oh, sorry, let me just go back. That was too quick. So if you're looking at live vaccines, you have a choice. You can either keep them alive, but just weaken them. And that's the little pink illustration. So that's what we call live attenuated. And these vaccines can replicate. So that obviously becomes a problem, especially in immunodeficient patients, which we'll get to towards the end of the talk. And in the blue, you can have a fully fledged particle or full vaccine or full virus, but it's killed or inactivated. So that's the top part, is using the whole pathogen or the whole virus in your vaccine development. At the bottom, the types of vaccines, other than the whole virus, is obviously using the parts of the pathogen. And that would be actually probably where we're going with most of our vaccination efforts, is to use parts of the pathogen that actually will lead to the strongest immunity and also to the best protection, be that outside proteins, be that virus-like particles, anything that our immune system recognizes as foreign and will mount a sufficient immune response to. And then obviously toxins, we've got 2 main toxoid vaccines, which you are all familiar with, the diphtheria and tetanus. And the reason we use the toxins and inactivate it to what we call a toxoid vaccine is that the disease or the illness actually is dependent on the bacteria producing this specific toxin. And so obviously that's what you want to target in preventing the illness. And then in the green, of course, a lot of talk, especially with COVID vaccines recently, and much more probably eloquent in a newer way of developing vaccines, is using the genetic material of the specific pathogen and packaging it in a way that the body will recognize and make a longer lasting immunity against. So then putting it just differently for you guys, as you can see there, you either have whole vaccines or component vaccines. And this is nothing new. This is very familiar to us as part of the EPI program. We have most of these vaccines that we can use in our armamentarium. And often then if patients talk about COVID vaccines and they're hesitant about COVID vaccines, I often remind them that this is sort of old news if you work with vaccines. And this is technology that has been around for many years, maybe just new applications as we sort of need to advance in our COVID vaccines. So this is just another way of telling you that if you look, for example, live attenuated type of vaccines, there's a whole list of vaccines that uses this technology. Most of you will obviously be very familiar with measles, mumps and rubella, yellow fever as a travel vaccine, oral polio, BCG. We all know about BCG and the development of BCG disease before we had early ARV treatment, and varicella zoster, which we don't use in the sort of EPI schedule, but certainly is part of the private schedule. This type of vaccine development has been since 1798 when smallpox was introduced. Killed whole cell organisms. Most of the older pediatricians will remember whole cell pertussis, and it's still used in many parts globally, and we all are sort of familiar that it has got a longer lasting immunity than the acellular pertussis vaccine, but it comes with more side effects. And so you always have to weigh up the effect and the side effect of giving any vaccine. Toxoid we discussed, and then you can see the parts of the specific pathogens you can use, such as subunit vaccines, virus-like particles, such as our HPV vaccine for our young teenagers. We can use the outer membrane vesicle, protein polysaccharide conjugate vaccines, and the well-known one is obviously pneumococcal and meningococcal vaccines, and then the viral vector and nucleic acid vaccines. And then there's always experimental vaccines, the last two in bacterial vector and antigen-presenting cells. These are all in experiment, and I'm sure in the near future, with new pandemics or new developments, you're going to see this type of vaccines coming through quite strongly. And so, as I suggested, as you discuss with your patients about COVID vaccine, this is really not what I wanted to discuss this afternoon, but just to give you an idea that many of the COVID vaccines that we've got actually use the same technology and use the same sort of packaging to package the SARS-CoV antigens for our system to recognize. And of course, with each vaccine, we do have adjuvants to enhance our immune response. And in the RNA vaccine, you can't be giving someone naked RNA. You need to actually package RNA vaccines with a nanoparticle to encapsulate and protect that RNA. Otherwise, it's going to degrade quite quickly. So we spoke about adjuvants, we spoke about the vaccine packaging, and it's important to understand if we vaccinate someone, we need a proper immune system. And I think we're going to discuss that next, is we're in a dilemma that we need to give vaccines to people that doesn't have a proper immune system. So you're sort of damned if you do and damned if you don't. And how do you think about that and discuss that with someone? So what we do need is, if we give someone a vaccine, what you can see here, I'm sure you were planning to do Immunology 101 this afternoon, is to actually have functioning cells that can present the vaccine to the lymph nodes, and functioning CD4 and CD8 cells that can produce both immediate and memory B cells, and also CD4 effector and memory cells that can respond with the next exposure to the infection. And so this, for me, if I look at this, always seems like, you know, if you look at those movie sets and the director needs to direct the whole movie, just many people, and they need to work together all at once to get the effect that you wanted. And for me, looking at a picture like this, you need that sort of symphony or that movie just to work and everybody to work together. But now you're in a conundrum where you do need it, but do you have it when you need it? And so let's look at the specific age indications and the reasons, and why are we giving so many of something at a young age? Why don't we just wait until someone is 2 or 3 and they have this symphony and they have this immune response that can actually adequately cause a proper immune response with this just one dose? Because that's really actually would be much easier, isn't it? And what we all wanted. So where does this age of vaccination come from? It comes from the fact that the first 5 years of life, and especially the first year of life, are the most critical when it comes to morbidity or mortality with these vaccine-preventable diseases. So in the first 5 years of life, this is the time and the age group where there'll be the greatest benefit from vaccine-induced protection. So you need to protect the young ones early on in their life against vaccine-preventable diseases. So that makes sense. All of us know that's when you see these diseases in your infants, in 2-3-year-olds. So it makes sense epidemiologically to give them a vaccine. But it really is quite an inconvenience immunologically, because they don't have functioning B cells, T cells to maturate. They don't have even IgG that they have the subclasses. They don't have proper IgG 1 and 2 if it comes to the polysaccharide vaccines. And so you're sort of, stuck between a rock and a hard place. And so, of course, then you have this first few months of life where we are all promoting to go to walk until term and to deliver as close to term as possible and to breastfeed as long as possible, because you do get protection from maternal antibodies. But then some people tell us that you can even get interference from maternal antibodies. And so there's been some suggestion that maternal antibodies might reduce antigen availability, might reduce viral replications in case of viral vaccines, and might perhaps regulate your B cell responses towards vaccines. And so you're going to sit in this sort of catch-22 situation where you want to protect the young ones, and they become vulnerable as the maternal antibodies decrease, but you're sort of in this gray zone where you need to give them maximum protection with sort of trying to work out where the interference is going to be and how you can overcome all of these issues. And so that's exactly what we're dealing with in the first 6 months of life, where there's a window of vulnerability where the maternal antibodies is not going to be enough to protect this little one, but the immunological maturation is still taking place on top of this risk of ongoing infection. And so you're sort of left with a situation where you need to give a lot of something to make sure that they get a proper response. And so for most vaccines that are used in the first year of life, we do need to get 3 or 4 dosages by 12 months of age to ensure that you've reached an adequate immune protection. So we call that priming. And so you hear me talking about primary doses or priming. And those are usually the multiple doses that you give up until the age of 6 months, followed later on by what we call booster doses. And that's usually the second part of infancy going on to older children. And so that's where this idea of giving a lot in the first 6 months of age and then topping it up, boostering, came from. And you can see there on the bottom of your screens, when we look at that, we generally look at the Tdap or the TDP schedules, the diphtheria, tetanus, and pertussis schedules. And that was started in 1974, the WHO schedule for diphtheria, tetanus, and pertussis containing vaccines had this idea that you had to give 3 priming dosages early on in life to actually have adequate protection in the first year of life. And they decided to have it at 6, 10, and 14 weeks. And initially, there wasn't any booster dosages. Over time, ideally, you want to give it a little bit later in an ideal world to actually stop with the maternal interference. And you want to give it a little bit more than 4 weeks apart to actually get time for this priming of your B cells and maturation to take place and to have a longer lasting immunity. And so in an ideal world where you epidemiologically have a disease under control, you have a high vaccine rate, and you have less of these diseases, you could probably look at giving it a little bit later and a bit more spaced apart. We don't have the luxury in South Africa, but as you see there in the UK and in Australia, they're sort of dabbling with this idea of starting a little bit later and spacing it at least sort of 2 months apart. And so why we have the schedule we've got is really almost a practical thing, is that in 1974, we started with 6, 10, and 14 weeks. And you can see in 1966, polio was given separately and sort of haphazard sort of in between until research said you can give vaccines together. Polio became part of that first 3 priming dosages. So that was added, as you can see, 30 years later. And then as we developed more vaccines and we could actually prevent more diseases, what we really did is we slotted into this sort of old idea of vaccination. And as you can see, we kept what we had in 1974, and we just slotted in vaccines around it. Now you're sitting with a sort of an ethical dilemma of asking yourself, is this really the best vaccine schedule? And I think most vaccinologists could probably sit and have a whole afternoon and chat with you and say that, no, ideally you can probably rearrange this to get more benefit out of less vaccine vaccinations. But from a research point of view and from an ethical point of view, you will have to show inferiority if you do research about it now. And so it becomes very, very difficult to change the schedule and to really sort of go and do research into the best practice if this is going to be used as the gold standard that you need to measure things with. And so I think that's what we stuck with at the moment. We've got a schedule that is working, but it was adding on to, 40, 50 years of a primary schedule, and trying to now prevent diseases on top of all the other things that we're trying to prevent, becomes a bit complicated. But that's where we started, like, as you can see, in 1966, and where we are at the moment. And almost close to 70 vaccines that you can give for a little one in the first year of life. So what type of vaccines would you then give? Is it full strength, half strength? We've got all of these specific vaccines and names, as you saw in the pediatric management group list. This is actually also fairly easy. It's not a difficult science. Originally, Tdap was developed, the full dose for young ones to protect young ones. And we wanted to give it to soldiers and to the military to go and fight overseas. And the UK thought that a lot of them came back with diphtheria and tetanus, so they needed boosting. And the diphtheria-containing vaccines actually had very high side effect profiles in older individuals. And so they realized that the full strength, what we call full strength Tdap that we use in the young ones, is actually unacceptable in older patients. You have a much stronger side effect profile. And they realized that if you decrease it to what we now call reduced dose, and that's why you'll see the pertussis and the diphtheria is written not in caps, but in small letters. So to indicate reduced dose that we're having in adults has got a much favorable side effect profile, but still a good immune profile. And so that's why you've got certain age indications for some of these vaccines. It's just based on when it was designed, who it was designed for, and what strength it was designed with. And you also can see here, for example, I have many patients asking me, well, the varicella vaccine is now out of stock. Can we not use the zoster vaccine in children? The answer is please don't. It's made for different age groups. As you can see, zoster vaccine is 14 times stronger than varicella vaccine. It's for the specific indication of zoster in older individuals. And so the vaccine was specifically made to combat zoster in older age group. Varicella vaccine was specifically developed to decrease the burden of chickenpox in younger infants and young children. And so because of that, that is the age restriction that you can use this vaccine safely with. And so although as pediatricians, we often dabble in off-label prescription of antibiotics and things, I wouldn't advise to go off-label when you're looking at vaccines. There's a specific reason it's designed. It's designed in a specific way to have a favorable immune versus side effect profile, and I wouldn't use it without getting the evidence and really getting the discussion and looking at what is safe in specific age groups. So what about catch-up vaccination? So some pointers. Catch-up vaccination is then where you have a personalized vaccine schedule. And this is for kids and adolescents who started late or more than a month behind. And the objective is really to complete their vaccine series, not to restart it, regardless of the time in between their last dosage and the time that you see them. Important now, we discussed vaccine types and ages. It's important to use the schedule that is appropriate for that child's age. Some vaccines might not be appropriate for use, so the child might be too old, and you could maybe have access in older children over 6 to other vaccines that might just be easier to give. And you obviously need to calculate the intervals between dosages, and just by conforming, we would usually use 28 days or 4 weeks. Just of interest, if you need to do a quicker vaccination schedule, as we said, you can go to 3 weeks if someone is, for example, immigrating and need to actually have a quicker schedule. You then have to look at age, minimum and maximum ages, at intervals. We went through all of this, so hopefully this is nothing new to you guys. And then obviously the number of dosages that you need to give. And that may decrease with age, or the child might not need any dosages for his age. And so if one or more vaccine is overdue, obviously you can give it all at once, except our MEAS bio. That is an exception because it wasn't studied together with other vaccines, so we have to give it on its own. All right, so how do you individualize? You start immediately. You review the previous immunization history and you decide whether it's what we call zero dose, meaning never vaccinated, or an under-immunized patients. You don't just restart from the beginning. You list all the vaccines that they missed. You check the patient's age and is there specific consideration. This we're going to talk a little bit about in the haberdashery, such as is the patient getting polygam or not? And is there an outbreak? You know, do we need to give measles immediately without thinking, and then we can have another month to sort out our catch-up schedule because you're dealing with an outbreak? Is there a hepatitis outbreak? You know, is there something that you need to pay attention to immediately? So this is probably the nicest thing to have close to you. That was our suspect catch-up vaccination table that we actually released 2 years ago, and I think it's still the nicest one for me, and I often go back to this if I need to sort out what vaccines I need to give someone. But let me give you examples. I think those of you that saw this talk on during the SAPA conference would know this. I have a zero dose and an under-immunized calculator. I'm probably saying I'm a bit of a nerd, but I do have it, so you're welcome to ask me and I can send it to you. So if, for example, you have a 3-month-old that's never been vaccinated and otherwise well, you can sort out a vaccine schedule like this. And immediately you can give BCG, polio, rotavirus, and your pneumococcal and 6-in-1 vaccine or Hexaxim that we used in the public setting. You can give all of that at once. So that'll be oral vaccines, BCG vaccine, and 2 other intramuscular vaccines. And you can let them come back a month later and catch up the last remaining OPV, Rota, pneumococ, and 6-in-1 or Hexaxim vaccine, because they're still young enough to actually get OPV and rotavirus. Now you're dealing in a specific situation where at 6 months, you've got a choice between giving measles and catching up that last 6-in-1 that he still needs. And of course, as we've discussed, you will need to start the measles first, always measles if someone is 6 months and older, and you will defer the 6-in-1 to a month later. And so it's easy enough for this patient to get vaccinated and get up to date as quickly as possible. A little bit more complicated if someone is under-immunized. And I think the message here this afternoon is nothing is 100% precise. You just need to follow the sort of basic guidelines. And some people will give more initially. Some people will keep to the specific ages and just go according to what's in the book. So at 10 weeks, we'll give 10 weeks. At 14 weeks, we'll give the 14 weeks, bar the ones that is not indicated anymore. Some people give as much as they can on the first visit. So there's nothing clear, but I wanted to show you this. So a 7-month-old that were given some dosages. So we're given the first dosage. Where are you going to go with this patient? OPV and rotavirus is not indicated. And that's really my main aim that I wanted to show you here, is that after 6 months, you're certainly not going to give rotavirus vaccine, or there's no need for OPV vaccine. So that doesn't need to be given. So you can catch up pneumococcal and your 6-in-1 vaccine, and measles you can leave for 12 months. So now, as you can see, I actually, in this specific example, I then said, let the patient come back 2 months later for another round of pneumococcal and 6-in-1 vaccine. Sure, you can let them come back at 8 months and give them the Hexaxim, and at 9 months, give them the pneumococcal vaccine. That is also fine. The reason for the second and the third dose, giving them a little bit apart, is really for the benefit of the pneumococcal vaccine, because the 9-month dose is really, in all fairness, the booster dose. And remember, we said there should be some gap between priming someone and boosting someone. You do need a little bit of a gap to have that B cells mature and get a proper secondary response to your booster. And so ideally, even you want to give this booster dose of pneumococcal after their first birthday. And so that's why I said this is where you can play around with it a little bit. But this is one example where you let them come back 2 months later and give them the pneumococcal, the 6-in-1, and off you go. They are by far and large now caught up, and they can continue with their normal vaccinations. So haberdashery, here we go at the end, little bits and bobs. What about preterms? Those neonatologists, all of you working with preterms, can't I vaccinate? So the routine immunization schedule, the dose the intervals, the contraindications are the same for preterm infants. So yes, you can vaccinate. You're not going to wait until they are term before you start with your vaccinations. Just a little bit of an exception here is we are not giving birth hepatitis B at the moment. It is something that the WHO is actually promoting, to give an extra hepatitis B birth dose. And it is something that we are discussing on a national level. So when that comes into play, and at some stage people will recommend a birth hepatitis B dose, what do you do with your prems? Well, anybody that's under 2 kgs at birth and are born to a woman that are B surface antigen negative, so you don't have to give it as post-exposure prophylaxis. The first dose of that hepatitis B should be ideally postponed until hospital discharge or 30 days of life, whichever comes sooner. So hepatitis B then in the preterms is really the only one to sort of look out for. And as you all are familiar, if there's a patient, a newborn that has been exposed to a mum that's surface antigen positive, that initial birth dose that you give don't count towards the general EPI schedule. You'll still continue with your normal 16, 14-week immunization and discard this as the first hepatitis B dose. Oh, look at that bruise. I wanted to put in another bruise for a hemophiliac patient, but I thought we don't need that this time in the afternoon. So what about children and adolescents with increased risk of bleeding? I don't know who of you deal with hemophilics or von Willebrand factors, or patients that have got a bleeding risk, patients on warfarin, the cardiologist. It was previously sort of said that patients that bleed should ideally have more subcut injections than IM injections. But IM injections, intramuscular injections, is safe. You just need to time it properly. So schedule your injections shortly after administration of clotting factors or before you start anticoagulant medication. So you need to plan it a little bit. Use a smaller gauge or smaller caliber needle. And I don't know about you, my mother used to just rub an anal. Do not do that. Press firmly on the site without rubbing and press for a little bit longer than usual. So it can be given safely, just with a few considerations. Oh, I love this picture. Look at that. Do you think any mum will let us give 7 injections at once? I don't think so, but how many jabs can you give at once? There's actually no upper limit to the number of vaccines. The answer is you're going to, as soon as you run out of place, I suppose. Importantly, if you do give multiple vaccines, don't be a cowboy and just get them all in one syringe and draw up 5 cc and inject it at one space. That's not going to work. And certainly don't give any vaccines in the buttocks. That's not where we should be vaccinating. So vaccines should not be mixed in the same syringe unless the combination, like the 6-in-1, is specifically approved. The site of injection, usually in the younger ones, is the anterolateral thigh. You can give 2 on both sides, about 1 inch apart. So that's about 2.5 centimeters apart. And then if you've got a little bit of a nice fat pad here, a little bit older infants, or especially after the age of 1, you can give it in the deltoid, but usually we start with the anterolateral thighs. What about vaccines and immunoglobulin preparations? For example, if a patient need hepatitis A vaccine and immunoglobulin because they've been exposed to hepatitis A in the house, yes, you can give it together, but usually different limbs should be used for each of these injections. And then moving on to obviously the question around other immunoglobulins and what should and shouldn't we be giving patients that are on immunoglobulin therapy. Before I get to that, just remember, the more you give, please be cognizant of talking to your patients about reducing the pain of vaccination, really sort of having a nice environment where you hold the patient comfortably, where you have a sister that knows what they're doing. If there's multiple vaccines they need to give it together at one site, or then at least to start with the one that's least painful. And we know, for example, if you have to give rotavirus vaccine, you can give that first because it's got a little bit of sucrose in it and it will cause a soothing effect. Obviously, if mum is breastfeeding, that'll be ideal to put baby on the breast as quickly as possible. So please work also towards a good environment if you vaccinate patients. And I'm sure Paul is going to discuss this as well. So what about immunoglobulin preparation? It really is not such a big issue. Most of our vaccines these days are what we call inactivated or particle vaccines, and they interact minimally with immunoglobulin preparations. So inactivated vaccines, toxoid vaccines, they can be given simultaneously or anytime before or after antibody-containing blood products. What you should be more cognizant of is when we get to live vaccines, and really the catchword here is live replicating vaccines. That's our main problem. So live non-replicated or inactivated vaccines, such as polio, rota, the live influenza virus vaccine that we don't have in South Africa, are usually not affected by blood or blood product transfusions. Here, the indication is really what is the patient going to do with this vaccine? What underlying immune defect does the patient have? And can he have this vaccine from an immunity point of view, not from the point of view of receiving immunoglobulins, and is it going to interact with immunoglobulins? But when we get to live replicating vaccines such as measles, mumps, rubella, varicella, MMRV vaccines, the efficacy may be decreased if you get these vaccines 2 weeks before or 1 to 2 months after administrating of immunoglobulin-containing products. And so usually we would say, is it needed? This patient is on immunoglobulin preparations, is on immunoglobulin replacement. So what is going to be the benefit of giving this patient a vaccine at the time of receiving an immunoglobulin product? Can't you actually give it after you've completed your immunoglobulin replacement therapy? Ideally, you should administer it a few months after you're finishing your IG administration, so 6 to 9 months later. Otherwise, if you feel the need to give it earlier, please count that as a null dose or a non-dose and should be repeated 6 to 9 months after completion of your immunoglobulin prep therapy. But so the message here is, far and large, most vaccines is not going to be a big issue. A little bit of a headache if you're dealing with measles or varicella containing vaccines. And there again, I left you with a vaccination in patients with immunosuppression. It's a 2014 article, but I think it's good, especially for the registrars, that summarizes the idea of why is the patient getting immunoglobulins? Is it because they've got a T-cell defect? Is it because they received chemotherapy? What is the underlying cause? And what is going to be the benefit of vaccinating a patient like that to the patient, and also long-term, and where do you go and how do you make those decisions? So it's a good article just to have close to you. All right, and so I want to end off that we are in a twindemic. I thought that's a fancy word. I think we're in tridemic because we've got flu, RSV, and COVID at the moment. But please be advised, as you advise your patients, look at this. Call your pediatrician, and it's the best place to be to talk to someone about vaccinating your child and protecting them against vaccine preventable diseases. And I want to end off with that to give Paul the platform on how to talk to your patients about getting these shots and avoiding a twin or a tridemic this afternoon. Thank you so much for listening, everyone, and I look forward to your questions.